like to invite Dr. Kamaljeet Singh, sir. He is head of ophthalmology at Allahabad Medical College, and he shall be speaking on Argentina flag sign. So we all know that capsular rhexis is not a prerequisite for. It is of course desirable to do a capsular rhexis, but it's not a prerequisite for SICS. But there would be situations where
Thank you.
in a intumescent cataract you have the Argentina flag sign coming in, and how you can manage these patients with a good SICS despite your rhexis not being in place would be now discussed by Dr. Kamaljeet Singh, sir. Sir, you ready?
Yes.
Can you please put his presentation?
Oh. So my topic today is if you encounter a Argentinian flag sign, what to do. The best way would be to prevent, of course, the Argentinian flag sign. But sometimes on a bad day, you would get a Argentinian flag sign, and you should know how to manage this case. You see, the SICS can be done with can opener technique, with envelope technique, or capsular access. The difference between these three techniques is that can opener you can make smaller, there is no problem in that. The envelope technique, when you do an envelope technique, it might extend on the sides and can go into the posterior capsule. And capsular access you should make about 6 millimeter size so that you can prolapse the nucleus out of the bag easily and then deliver the nucleus out. So these are the three things that can be done, but at times even if you are doing 100% good capsular access, you might find this kind of problem. And SICS is best if you have this kind of Argentinian flag sign that you can see on this screen. So this is a very, very important thing, and that is why this name is that you have stained the dye, the anterior capsule with the trypan blue dye, and when you have a hypermature white cataract in the center, you get a reflex of the cataract after the extension of the rhexis occurs. So this is my video wherein you can see as Dr. KPS Malik and Dr. Ruchi, they are my teachers, and I always make the same kind of incision what they make, a frown shaped incision about 2 millimeter away from the limbus, and go gradually. There is no hurry of finishing the surgery in 2 minutes. And many a time we tell our students that there is a Japanese association of slow surgeons, so that you make a perfect. हम लोग कई बार अपनी शेप भी कराने चाहते हैं तो नौवे से कहते हैं यार जरा धीरे धीरे बनाओ, बाल वाल छोड़ना नहीं. And when we are doing cataract, we say that we finish it in 1.5 minutes, and you might have an accident if you are doing it faster. So you make a good tunnel and then you puncture the anterior chamber. I usually do it. You see, there is a pressure inside, air bubble is not going easily and it's coming out. And we have stained this anterior capsule, which gives you a contrast, and therefore you would be able to do a good capsular access. The important thing here is that you should use a high viscoelastic, and many a times we use a high molecular weight viscoelastic, but still the chamber deepens. The purpose here is to deepen the anterior chamber so that the pressure to the sides is prevented, so that this rhexis may not extend into the periphery. So we keep on putting the viscoelastic in the anterior chamber in the hope that the interlenticular pressure would be reduced and you will be able to do a good capsular access. So then we are injecting lots of viscoelastic to deepen the anterior chamber, and whether I use capsular access, I just did a small nick there in the center and then again injected viscoelastic material to deepen the anterior chamber, but there was this higher pressure inside, and then I tried to hold the capsular access and the viscoelastic again got out, and I thought that I would put this, and you can see the Argentinian flag sign as I have shown you the flag there, and on the sides you have the blue appearance, in the center you have this road kind of thing which is and in the center if you have a sun, then it is of course exactly like you have Argentinian flag sign. So then we have to do now at this stage, we have to think what we can do so that we can solve the problem of delivering the nucleus out. Here, phacoemulsification is absolutely contraindicated, because what happens that these two edges on the extreme side, they might go in the periphery and may go into the equator, and from there it might go into the posterior capsule, and you will have posterior capsular rupture, and you will not be able to see because the cataract is opaque, and you will not be able to see. So that danger is there. So what you have to do is that all maneuvers that you would be doing would be in the anterior chamber. If you do it inside within the bag, then this extension will occur, like it occurs in envelope technique also. So now what we do is that we have a flap here, and inject more viscoelastic. I give a small nick there, and then with the help of capsular access forceps again, we try to make a semi-lunar capsular access, I would say this. So this is made on this side. Again, we make a nick. Here the flap is big, so needle is not used. We are using a vanas, and we give a nick there and try to enlarge. Rather, it's simply enlarging the opening so that the prolapse of the nucleus becomes easier. So now what we do is that a little we extend it, and extension should be slightly larger because the nucleus is quite large, and so that the delivery becomes easier. And then what you do is that you give a little bit of fluid there, and you will find, because there is pressure is high inside, so it will automatically come in the anterior chamber. Then you don't need to do too many maneuvers here because of the chances of extension of the rhexis. Now with the vectis, you simply take it out because your incision is large, so easily it will come out, and then visco express the epinucleus, and you will find that your surgery is over. Then you use Simcoe cannula, and be careful, don't push it too hard, otherwise here also the extension might occur in the periphery. And after injecting viscoelastic, you can see good reflex, and the rhexis margin is also seen in this side. It has not extended into the periphery. And then you implant a non-foldable lens, and we'll put this haptic beneath the capsular rhexis margin on this side, which can be seen easily. Simply rotate it, don't do too much of manipulation there because of the chances of extension again. So this is what is done, and you will find that your surgery is complete and your pupil is round. There is no problem in this. So you finish off the surgery like this. So basically what I want to say is that in case you get it, and even if you have planned a phacoemulsification surgery, convert it to SICS, bring it into the anterior chamber, and your surgery would be nicely done, and you'll be able to finish the surgery in time without any complications. Thank you so much.
Thank you, Professor Kamaljeet. So you have seen that when you have the situations of hypermature cataract and the flaps run away, that you cannot do the rhexis, still you can manage the SICS. As he told, it is difficult or impossible to do phaco in it, but at least I manage phaco in these patients with a high vacuum, and you hold the lens, the nucleus, little, take it out, kind of just keep on holding on the high vacuum, 500, 600 vacuum, and you have anterior chamber maintainer, so you can keep on rotating it like a ballroom dancer and can keep on eating it. So phaco is manageable in some of these patients, and you learn it over the years that you can do it. And he has done very well about the SICS. Is of course, when you run away like this, the rhexis is not in the place, so SICS is a way to go forward, and you get a very good result. Other thing I wanted to say that patient want sometimes that I want foldable lens. So you can put foldable lens in all SICS patients. There's absolutely, routinely nowadays I put the foldable lenses in all SICS patients. So lens is not a problem, can be put foldable. Thank you, Dr. Kamaljeet.
1 minute. So you see what we can do. I usually use this forceps for doing this rhexis formation, but you can go through the side port because there the incision is very, very small, and the chances of extension may not be there because visco then does not come out of the wound. So you can use a side port also and do with a cystitome, or MVR, vitreoretinal surgeons, they do this microforceps they use, that can be used for making the rexes. Thank you, sir.
You know, these days microforceps are available which can go through the side port for doing rexes. So you can maintain.
So in fact, just to add, there were couple of things which I just wanted to add. That one was that the moment you identify that there is an Argentina flag sign, avoid all turbulence in the interior chamber. The more the chamber is going to be turbulent, that is the shallow and the deep AC should not be there. It should be a stable chamber. The more the chances of this rex is going to wrap around, that is it will extend to the posterior capsule. So one has to be very careful that the moment you see it, please either you just put a viscoelastic till or you're searching for your instruments and all that.
Yes, that is what I did
Yeah.
actually. I kept on injecting
Yeah,
viscoelastic.
and the other thing is, of course, if you have hold of microforceps, they are actually much better because then you're working in again a closed chamber, so your turbulence again decreases. But most of us would not be carrying microforceps all the time. But if you can actually plan and keep a set aside for this purpose, it really helps in all these patients.
Sir, can I share my? What I do in such cases, first of all, it's excellently managed once the Argentinian flag sign has happened. But what I do, I always do rexes in such cases from the side port, and one mini rexes using the 26 gauge of needles. Then it can be enlarged. Okay. So in that case, I think, sir, your viscoelastic in this case was the HPMC. If it would have been sodium hyaluronate and all that, so it could have better thing.
Rexes also, you can make a small rexes in the center, then you can extend it later also. But when you get this Argentinian flag sign, the moment you enter into the anterior chamber with a needle, you will find that your extension would occur without even, it does not give you much time.
Sign.
Yes,
It's a frightening sight. When you see this one, that it just runs away, you really feel. So take deep breath, wait, and then plan next move. Thank you very much, Dr. Kamaljeet Singh.
Thank you.